Uh, yeah, before we talk about the next 30 years, where we have nothing to do because AI does everything for us, we are still in the phase where we have to be active. So one of the actions that we do is by taking biopsies. And I'm very happy to introduce Dara Kraitchman from Johns Hopkins University. She will present her experiences on biopsies, why to do, where to do, how to do. And I'm very happy to have you here. Thank you for your presentation, Dara.
Well, thank you for the introduction. I want to thank Jürgen and Sophie who really planned this session, and I've kind of enjoyed some of the interesting debate. It's the second time I've been invited to Greece and not actually get to give a talk and not actually been there. So I'm hoping the next time I actually can show up. So you'll notice that my degree is actually a VMD. So I'm actually a veterinarian, and I do interventional radiology. And so this is sort of, I started in cardiac mostly and then moved over to more vascular interventions. But I'm pleased to talk about what my experience has been with MR guided biopsy and some other groups. I have a few disclosures that are listed here. So endomyocardial biopsy, it is considered the gold standard for diagnosing myocarditis, and it's probably where it's most frequently used is in heart transplant patients, where they get repeatedly biopsies, especially in the early period after transplant, to look for heart transplant rejection, since the patients themselves really can't feel any pain after the transplant. To a lesser extent, I would say that it's being used for things like ARVD, and this session is sort of more on arrhythmias, but we do know that, again, to confirm cardiac tumors, sometimes for sarcoidosis, it's been used. So a lot of sort of inflammation that we're seeing or immune-mediated disease to the heart. Almost universally right now, they're performed from in the right ventricle, taking samples sort of randomly, usually 5 or more, sometimes as many as 10, under X-ray fluoroscopy. So we all, I'm sort of preaching to the choir here. We all know that you can't see the heart wall very well. So you're just sort of hoping that you are able to achieve, get a piece of tissue that actually is diagnostic. It has a relatively low complication rate, but there's a little sort of motion on my slide. But as you do these repeated endomyocardial biopsies, EMBs, the complication rates tend to increase. So we can think about heart transplant patients that doing it once or in an individual patient, we're looking at a risk rate of about 1% of complications. But as you repeatedly start to take tissue of the heart, and because of this random sampling, we can often miss patchy disease. And clearly, CMR is very good. We just had a talk on, and we had a lot of debate about the late enhancement in the atrium, but definitely in the ventricle, it's a lot easier to appreciate. But sometimes it's not even in the septum. It may be in the free wall, as shown here. This is taken from a paper by Ota et al. And sometimes you don't see any late gadolinium enhancement, but definitely if you're trying to get sort of these fibrotic areas or these abnormal areas, being able to target using CMR to the wall is helpful. And so as a first stopgap measure, and I'm not going to talk about this, is some groups have actually done overlays of the CMR from either the late gadolinium enhancement or just even from cine imaging on a meshwork or framework with the fluoroscopy. So done this X-ray fused with MR to do more targeted samples. But when you really get down to it, the diagnostic yield is much higher if you could do this all under CMR guidance rather than X-ray fluoroscopy or a fused. This is a nice paper. I feel like we haven't moved a whole lot in this area in the last decade. This paper is from 2016. Toby Rogers and the Letterman lab did this nice study in swine where they did this pure X-ray guided biopsies as well as targeted CMR guided biopsies. They had taken the swine and injected a fluorescent microspheres, and then they looked at these samples and they showed, and this is pretty typical of what we see in patients. About 50%, there was like a 50% yield of the actual targeted tissue with X-ray fluoroscopy, which went up to about 80-some% in the swine model with this a CMR biopsy. The reason that their yield probably wasn't higher is that they were, let me go forward a slide, is because they had an active device, but they had some issues about how they could actually steer that device. So this is some nice data that I received from EPFlex, which is trying to commercialize a MR guided biopsy device. So if we think about what the challenges are for the CMR guided biopsy device, is they have many magnetic components. There's steel, the jaws are in steel. You have these little springs for the opening and closing the jaws. There's a pull wire to actually steer this biopsy device. So all those things are very likely to heat. And so one solution that EPFlex has come up with is they are actually making the jaws out of a titanium material. So we know a lot of titanium implants can be imaged with CMR. So it's not totally non-magnetic, but less magnetic. And then instead of having pull wires, they've made everything out of plastics. They've glued on the actual biopsy device. And so they've developed a sort of passive marker system where they just have a negative artifact created by this biopsy jaws. And then they can't really see the catheter. They just use these markers to tell where it is. And it's that right now they have it as an MR conditional device. So they have used it now at 3T, again, in just a swine model. And so you can see here, you have sort of a negative artifact from the biopsy device. The jaws are shown as a much larger hypointensity in the ventricle. They do have some steerability, so they can get to various areas, and here especially it's in the free wall. And they were able to show that using these various different designs of their titanium biopsy device, they were able to get actually cut into the myocardium successfully. So that's one of the challenges, is taking not only in having, like when we think about EP, having a device that doesn't heat and can actually ablate, but in this case, we will actually have to have the mechanical strength to cut and take multiple biopsies. So as I said, these jaws have to have some degree of mechanical integrity for harnessing, for cutting, and as well as multiple sampling. At the same time, we want to have minimal artifacts, and of course, we don't want them to heat. So our approach has been slightly different. If you think about clinical biopsy devices, they're made out of stainless steel. There's different ways that one can measure hardness. And so we've actually moved to a molybdenum Romium or Moray alloy that has a fairly similar hardness to stainless steel. So we feel like, unlike titanium, which is essentially a lot softer than stainless steel, this will actually give us a very, very similar biopsy jaws. And as you can see here in a phantom, the artifact or hypointensities are relatively small. So we have about a device that's about 2.5 millimeters of the jaws, and we see about a 3.1 millimeter artifact, and this is using an SSFP type of imaging. So instead of having a large blooming artifact like we saw with the titanium jaws, this sort of minimizes that artifact. So with that in mind, we've been very interested in developing and let me go back, an active device. And so this actually has a way to plug it into the coil ports of the scanner, as well as be able to open and close those jaws. So you can see here's an X-ray biotome. This looks very similar in size at the jaw point, and we can use this spring-mounted area to actually open and close those jaws. So it's a very, very similar device mechanically to what we're familiar with as using for X-ray biopsy. But in this sense, instead of having a hypointensity, we've actually built this with a loopless antenna, so we can actually see the device. So now, since this is an active device, unlike a passive device, so there is this potential to heat. And so we've done sort of extensive testing because, first of all, those jaws, although they're made out of a moire alloy, they actually have to be laser welded onto the actual components of the imaging coil, or in this case, a loopless antenna. And so we create what's considered sort of the gold standard, at least in the US, for testing devices for heating. So we have this large sort of gel-filled torso phantom, and we actually have the device going not in the center of the phantom, but on the edge of the phantoms where you'd expect the most heating. And this image here displays the sort of uniform electric E field that we use for calibrating. So this is very similar to a torso in a person. And so we test not only for mechanical integrity, but actually imaging artifacts and then heating of this device. And so that entails using a sequence similar. So we try to do 4 watts per kilogram SAR whole body as a protocol, which is sort of the testing that's required for, at least in the US, for passing as an MR conditional device for looking for heating. And so we do this for a period of 20 minutes, and we have little fiber optics that allow us to look at where the heating. So even where the biotome enters this gel, we can see some slight heating. And that's pretty typical. If you were to continue scanning continuously for 20 minutes in somebody's body and there was no blood flow, there'd be some heating occurring. The most important parts are the tip of this biotome, as well as down the length of the biotome. And we see that we have some heating, but it's still less than this 3 degrees C. We'd really like it to be about 1 degree C overall, but it's a little bit higher than that. But this is actually if we were actually imaging continuously for 20 minutes. So knowing that we have no blood flow and we're going to be using this in the left ventricle, we're relatively certain that we can actually sort of move on to testing this in vivo, because the blood is a tremendous cooling agent, can remove a lot of that heat. It's unlikely that we're actually going to hit those levels, and we're not going to be imaging continuously for 20 minutes either. So this is really it's very similar to our device that was done, again, about 10 years ago by the group at the National Institutes of Health, Toby Rogers and Robert Letterman. And you can see here, by making an active device, and unfortunately we've kind of lost these abilities, but in our imaging, we can actually take the active device, instead of just having as a high intensity signal, we can actually make it appear as a colored color. And that really helps you distinguish that from the surrounding anatomy. So there's just a receiver coil receiving your actual device, as well as you have the normal surface coils giving you an anatomy. So it's kind of the best of both worlds. And unlike what we were seeing previously with some of the EP talks, where you can have sort of this shell of the heart and you can actually do tip tracking, in the ventricle, because you have many, many different planes and it's a much bigger object, if you try to track the tip of the actual device, it's going to be moving around and going off screen. And I can tell you, I've really tried very hard to have multiple tip tracking devices and define 3D planes, and my device goes all over the everywhere. Their device actually had a slightly bigger, slightly different jaws, slightly different ability to have that hypointensity. But this is sort of the same sort of characteristics, and where we really need to be with the vendors as far as how we can visualize these devices. So that was done in a pig. So the problem they had in that prior study was that they didn't have any way to steer that biopsy device. So they ended up not being able to reach many parts of the ventricle. So we've sort of developed this similar to, rather than trying to create the steerability in the biotome itself, we actually want to have a sheath that allows us to steer to different parts of the ventricle. So most of your steerable sheaths that we use for X-ray fluoroscopy contain some sort of braiding in them. And that braiding is going to heat, it's magnetic. So we have to use a sort of poor man's version of this. We use Kevlar to create some polymeric braiding that allows us to get some stiffness to that sheath, because you're 100 or more centimeters away from where the handle is torquing it. And so you need that to go all the way to the tip. So that actually creates a lot of constraints on how you're going to build this device and why you need this specialized material. We also incorporate a pull wire that, again, this wire has to be magnetic. And again, that's made of Kevlar. And we want to be able to deflect this device once the biotome is in them. And trying to constrain this to make this actually a lot smaller, and thinking about how we would really want to be using this perhaps for pediatrics that were concerned about radiation and the amount of radiation in children, as well as the radiation to the operator. We want to make these devices as small as possible. So in this case, instead of making this an active device that we're going to track, we actually made this a passive device, and we placed iron oxide markers on it at various different points. And then we wanted to be allowed have the biopsy forceps extend on this. So here you can see we can have a great deal of deflection, but at the same time, we can still extend this biopsy device outside that. And so overall, although it has a relatively small lumen, all these requirements, we end up with about a 12 French outer diameter, which is approaching sort of the largest device that we'd ever want to consider in pediatrics. Not a problem for adults for biopsies, but my concern is my patients are actually pets, and they're small. So they're basically like pediatric patients. So how do we go about actually doing the whole complete left ventricular MR guided biopsy? It's not as simple as just, okay, we jam that biotome forceps. We actually have to do this non-invasively. And so we would do it similar to left heart catheterization. So first you would use a pigtail and place the pigtail in the heart. And in order to do that, we actually relied on sort of more off-the-shelf things that are still have been developed prior to us and not in ourselves. So we use a active nitinol guide wire that was originally approved for Surger Vision. It's called the Interceptor. It's a 0.03-inch guide wire. It allows us to put it in a just off-the-shelf, non-braided pigtail catheter and have an approach into the left ventricle. This is then after we've reached the left ventricle, then we just do an exchange. And so we take this active guide wire out and we exchange that for a passive guide wire. And this is actually a guide wire that's being developed by Nano4 Imaging. It's an extruded guide wire. It's non-magnetic, made of a polymer, and it actually has multiple markers. So it has 3 markers spaced about 1 centimeter. So the ability is to tell and make sure that the wire is extended long beyond your pigtail can be used by looking at how these 3 markers are moving around in the ventricle. So once we have that passive guide wire in the ventricle, then we're going to exchange that for the steerable catheter that I showed you. The steerable passive catheter is then advanced over the Nano4 Imaging guide wire, the passive imaging guide wire, and then that guide wire is removed. You can see as it's coming out, we lose that void of the guide wire. And then the next step would be to actually add our biotome after we've exchanged for this passive guide wire. So in the end, what we want to have is be able to see our biotome. And so normally, when we want to make these presentations, we show these images that are just beautiful, but the reality of it is we want to just do these actively. And as you sort of, as you proceed and learn how to do these catheterizations, you become less concerned about getting the manuscript valuable images and videos for presentations, and that can show you the whole length and get in the appropriate planes, because you can imagine there's many planes that you could end up in the ventricle for looking at this. So we've done our initial testing to look for the ability to obtain these biopsies, as well as the ability to not cause any harm, see side effects, and looking at the chronic effects of this in a dog model, because that's ultimately where I want to be having these studies going. So here, once we have the active biotome in the guide catheter, you can see a negative artifact, and we can see as we move into various parts in the ventricle. And here we're trying to do multiple sampling along the free wall of the ventricle. So not do specifically the septum, which is what is normally done from a right-sided approach, but actually do a more dangerous area to go, which is in the free wall, and worry about perforation. And so our goals are to actually we can see that as the biotome moves into position in the free wall here, how the jaws open, it creates a slightly different signature. We take a piece and then we move on. And we continue to do this repeatedly, getting upwards of 5 to 10 samples. So how do those samples look? They're fairly uniform. They end up being, samples that are very, very similar to what we see when we get, when we take X-ray fluoroscopic biopsies from this biotome. So using this Moray alloy allows us to actually get repeated many times, up to 10 samples from a single biotome. When we look at the heart acutely, we do see some hemorrhage, which probably if we were actually to look at our patients, we would see that as well. Microscopically, we can see some hemorrhage that occurs, but our biopsy pieces are very, have very nice margins, very easy, potentially, that if we were to look at some pathology. And the key thing is that as we've done multiple animals, we find that our mean diameter stays right in that 1 millimeter. So that amount of sampling that you need to be actually diagnostic. We do see some of these luminal tags from actually where we've taken the biopsies, depending on the trabeculation of the heart in that region. So where do we go from here? So my group is, so we've sort of done the initial safety testing, looking at this in both acute and chronic cases in dogs. As I said, I run the Center for Image-Guided Animal Therapy, where we do interventional techniques on people's pets. And really, my pets mimic a lot of humans. They're about the same size as our pediatric patients, which is really one of the areas that we want to target for cardiac MR-guided biopsies. That's because of the radiation dose. So, we're working on that. If we think about the patients that we're really probably going to be doing, for at least for my canine patients, they're comparable to heart failure patients. We know there's over 15 million people with heart failure in Europe. Of course, as the population is aging, those numbers are continuing to increase. The heart failure has been a contributing cause of death in 1 in 8 in 2017, and that numbers have been rising over the last decade. Unlike people where, I'm sorry if it advanced, unlike people where only about 20 to 50% of the heart failure is genetic, we know there's a worse prognosis when people have fibrosis. So in comparison, our dogs, about 1 in 10 of our dogs over 5 years of age will have heart disease. 3 to 4 in the 10 dogs over 12 years of age have heart disease. We're really limited in cardiac interventions with our pets because they're small size, and coronary artery bypass has really been perfected by some of the Japanese group, but is really of limited availability in most other countries. So I'd like to sort of point out to you, even though we were sort of talking about arrhythmia group, our target group is actually a non-ischemic dilated cardiomyopathy. This is very prevalent in a variety of large breed dogs, including Doberman Pinschers, Irish Wolfhounds, and a variety of others. And because these purebred dogs have been so tightly have such a tight genetic pool to make these purebreds, their incidence can approach 50%. And in several of these breeds, we now have multiple genetic tests for detecting this dilated cardiomyopathy. So we can test these dogs at 2 years of age and know there's a high likelihood that they're going to develop dilated cardiomyopathy and typically they're followed by echo. They usually have a 6-month lifespan once they've developed any sort of dilated cardiomyopathy, and they'll die of sudden cardiac death. So it's a very severe and rapid decline. So we'd like to be able to take these dogs, use CMR, do targeted biopsies to areas that we maybe look at changes in cardiac energetics, and then use these to sort of predict whether we can initiate therapies before they've developed dilated cardiomyopathy clinically to prevent these diseases, with the hope that maybe we can identify similar mutations in patients or actually therapies that could be helpful. So in order to do that, what do I need to do? I still need to complete some more safety testing. We're really interested in working on further miniaturization of this endomyocardial biopsy device. And one of the ways we can do this is using some flex circuitry. So these circuits are very small. We can incorporate these into some transmission line technology that allows us to, I talked about in vitro, I had a 3 C heating. With these transmission technologies, if I can still maintain enough signal, I can drop that heating to just virtually none. And then my biggest plug is that, I have not seen any great strides in actually the interfaces, and they've actually sort of declined, in my opinion, and the MR manufacturers are relying on companies like Imicor and others to develop specific packages that they can then interface with the scanner in order to actually visualize these devices for interventions. So we really need those combination of 3 things together. I think that'll make us really comfortable treating, in my case, pets, but also people with cardiac MR guided endomyocardial biopsies. And so I'd just like to thank, there's a group that supports me back at Hopkins. The group at NIH has been really instrumental. They allow us to use some of their equipment to actually build our devices. I want to thank the group at EP Flex that actually allowed me to borrow some of their slides about their sort of passive device that they've developed, that they're really trying to work hard to get into patients as well. And then, of course, my granting institute is the National Institutes of Health for this. And I've received some support from Siemens as well. And so I'd be happy to take any questions there might be.
Yeah, great talk. Thank you, Dara. I think we learned a lot about the similarities between babies and dogs and heart failure, so it was quite new for me. And I think it's also very astonishing that the heart is a very active energy producing and consuming organ, and we don't know much about that. So I think in many cardiomyopathies, we have no clue what happens on the level of the muscle, and to have biopsies to understand the disease would be extremely helpful. But at the moment, we don't do that because, it's the success rate and complication rate, costs, and availability is not so good. But I think it's astonishing that we have so many cardiomyopathies that we don't understand, and we don't go into them because we have no biopsies. I have a question.
Actually, I don't know if I made this really clear. I don't know if one of my slides got skipped or what, but the actual complication rate in peds for biopsy is really a lot higher. You're talking about that somewhere, especially for pediatric patients with cardiomyopathies, they often have like a 15 to 20% sort of complication rate. So it's much higher than what we see in the adult population. And they're also at the biggest risk to be exposed to all this radiation. So they're sort of the ideal population to go after if we're going to be doing these sort of blinded and actually may have more targeted biopsies.
I have a question, Dara. You mentioned the active device that you finally tested. Does it mean active in terms that you can bend and target a lesion, or is it active that it is visualized with an active coil?
So it has an active coil that allows us to see the length of the coil. We're actually trying to incorporate into that. There is a slightly different signature with the jaws open versus jaws closed, because that actually changes the tuning of the whole device slightly. So we can actually sort of not only have that tactile feel that you're actually against the heart wall, but actually in grabbing something, but you can actually sort of see it opening. Sometimes we'll bump out and do high resolution imaging while we're actually doing the biopsy to try to look at that more closely and see exactly where we're targeting. We've decided that as far as the steerability, that for the biopsy device, because we're developing some other devices to inject in the myocardium, the steerability is in the sheath, and that sheath is passive, but even because it has the active endomyocardial biopsy device inside it, we can see that sheath, and we only use passive markers to sort of see where the bending point is. So that just kind of gives us, so we know where we can bend from. And that's just an iron oxide. And we've sort of tuned that. So it gives us a little bit of signal, but not so much that it blows away the rest of the imaging that we can see.
It's quite interesting approach. This combination of
it has the benefit too that, like, because there's a lot of components in our biopsy device, it's not purely a mechanical device, but it's actually an active device. If we should actually, like, after, let's say after 5 biopsies, you actually, and you're pulling that device and putting it in and out with each biopsy. So you want to see it going in and coming back out. If during some of those, the actual imaging part of it should fail, you can just swap out a new biopsy device and you still have your sheath in there. So that's sort of the advantage of making the sheath itself steerable and the biopsy component active by itself.
It's really interesting approach to have a passive imaging of the actively steering device, and the biopsy is passive, but it is active with the localization.
Yeah. I think honestly, I would make them both active, but it's the size, and we're trying to reduce size. And every time you have to put a wire in there, we have a pull wire just to make it steerable. If you added another antenna in there to actually see that sheath, that would make it much larger than 12 French and just complicate the actual production.
Yeah. Thank you. Yeah. And another question in the meantime, is there quite a learning curve for the interventionalists if they do these biopsies to combine the two devices? Do you see that they perform much better after saying 10 cases, or it is easy from the beginning?
I think because, I'm working with cardiac interventionalists, that it's sort of, the way we go about doing that and the exchanges are somewhat similar, a little bit more complicated, but once they get the hang of what they're visualizing, it's just, we're exchanging we're just putting a pigtail in sort of like you would normally. It's just the visualization. And I think our biggest hurdle was how to, we do a very similar setup to yours. We have optoacoustics, so the people in the room can actually communicate with people outside the room. We have an in-room monitor for looking at what's being scanned, so we can say change these planes. We actually have somebody at the console driving the scanner. So it's really dependent on training the person to get into those sort of bookmarked planes for visualization that you're looking for what you're targeting. And I think for the cardiac interventionalists, they pretty quickly pick up on what they need to do. And because they have a headset that avoids that acoustic noise, not having to have lead is always kind of attractive.
Good to know. And yeah, I'm keen to see what you will present next if you go for probably larger series with this device. Are there questions, Panos, Sophia?
No, from my side.
No, I think I'm just wondering how much is the sensitivity and specificity of biopsy performed through CMR compared to the catheter biopsy. I mean, to the dynamic performance.
Right. So that'll come to bear as to how it works out for a final device. I mean, if you go back to the Rogers paper in 2016, I mean, they had like a 30% increase of their sensitivity for actually targeting the correct areas. And really, it would have been higher, but they just couldn't reach certain areas that they wanted to target because they didn't have a steerable biotome at that point. So they were limited in where they could actually sample. I think that's always going to be something that, as there's a trade-off between the steerability, the biotome and its stiffness, mechanical imaging visibility, and where you can, all the regions that you can target. But you definitely can decide where you want to biopsy and try to look at how much air and where you biopsy is that important. This isn't going to help us get at like epicardial lesions because we're coming from the endocardium, but maybe if we have mid-wall lesions, we can get closer to those mid-wall lesions as well.
Oh, great. Very important.
Good.
Thank you.
I think, yeah, we are looking for the next steps that you do. Thank you very much, Dara, for your insight into biopsies and your work in particular. So we will move on.